Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Immunotherapy, facilitated by Dr. Singh with Suburban Hematology-Oncology Associates. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs. So welcome everyone to today's program, Frankly Speaking About Immunotherapy, featuring Dr. Singh. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include virtual support groups led by licensed mental health professionals, stress reduction classes like yoga, tai chi, and meditation, a nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and of course, education programs like these. And if you ever miss a live event, you can visit the video tab of our website where you can find recordings of past programs. So for additional information, again, we encourage you to visit our website, cscatlanta.org. As a reminder, everyone will remain on mute for the duration of today's program. We invite you to enter questions into the program chat box, which Dr. Singh will address at the end of the program, time permitting. I'm excited to welcome today's program presenter, Dr. Singh. Dr. Singh joined Suburban Hematology-Oncology Associates after a 3-year fellowship at East Carolina University. Prior to his fellowship, Dr. Singh was a specialist in internal medicine at Pitt County Memorial Hospital. He also served as the chief of the Department of Internal Medicine at Sampson Regional Medical Center. Dr. Singh is board certified in medical oncology and hematology. He has twice won awards as an outstanding physician in patient satisfaction. So with that, welcome Dr. Singh, and I'll pass it off to you to begin today's presentation.
Thank you, Katie. Let's, without further ado, move forward. And I'll go through disclosures. I have no financial disclosures here. So this is an overview. Today we will do what is immunotherapy. Is immunotherapy right for me? What should you know about clinical trials? Types of immunotherapy, possible side effects, quality of life, future of immunotherapy, and in the end, we'll do question and answers. So what is immunotherapy? So immunotherapy is a type of cancer treatment that uses the body's natural defenses, which are immune system, to identify, attack, and kill cancer cells. The immune system is designed to attack a cell it sees as unhealthy or abnormal. Immuno-oncology, this is a field of cancer research that works to understand the immune system and how it interacts with the cancer. Finds ways of using our own body's immune system to treat or prevent cancer. So the immune system, your body's defense system against disease, it prevents or limits infections by recognizing and destroying foreign substances like bacteria, viruses, and also our abnormal or unhealthy cells. These virus, bacteria, or abnormal cells often carry tags on their external membrane or surface, which allow our immune system to recognize and attack them. These tags are called antigens. The immunotherapy treatment fight cancer by either boosting the immune system so that it can be better at fighting the cancer. It works by marking the cancer cells so that the immune system can see them better to find and destroy them. Helping the immune system find cancer cells and delivering treatments like chemotherapy, radiation, or even T cells directly to the cancer cells. How is immunotherapy given? So many immunotherapies are given usually using an IV infusion through a vein. It can be given in a doctor's office, clinic, or even as a hospital as a outpatient in a day patient care. Different immunotherapies are given on different schedules. They may be given in combination with other therapies or with another different immunotherapy. So what is our immune system? So immune system consists of cells, tissues, organs, that work together to protect the body against the bacteria, viruses, parasites, fungi, and other abnormal cells like cancer cells. T cells, this is a kind of white cell. T cells are an immune system soldier. They help protect the body from infection and can also help fight cancer. They are also called T lymphocytes. So they're a subtype of white cells called T lymphocytes. Antibodies, a protein made by our body's immune system to attach to a specific foreign invaders such as bacteria, virus, and potentially cancerous cells. Tumor antigen. This is a substance produced by our tumor cells that can be recognized by the body to create a specific immune response. And then biomarkers. This is a molecule in your body that the doctors can measure. Biomarkers give your doctor specific information about your cancer, and they can let doctors know if the tumor has a good chance of responding to certain treatment. So key things to know, it is very important that anyone receiving immunotherapy let their healthcare team know right away if they develop any side effects. Although these are promising, there are promising results, immunotherapy does not work for every patient who tries it. Side effects may occur even after you have completed the therapy, so it has to be monitored on an ongoing basis. And then there is still a lot of research, researchers don't know about immunotherapy. So this is a fast evolving field. So the questions researchers are trying to answer: why do immunotherapy treatments work so well in some patients and not at all in others? And then how can they be combined with other treatments? When in a patient's course is the best time to use the immunotherapy? And then what are the long-term side effects of the treatments? So next is immunotherapy right for me? So who is eligible? Most patients who receive immunotherapy today have cancers that are advanced or metastatic, meaning stage 3 or stage 4. Their cancers either have returned or spread after initial treatment or were diagnosed initially in an advanced stage. Some immunotherapy drugs are now approved to treat early stage cancers also, and researchers are testing immunotherapy in new cancer types and at earlier stages. So some patients, people cannot receive immunotherapy because of underlying serious health problems. For example, autoimmune diseases that make it unsafe to take these drugs. So if people with autoimmune disease, they already have a revved up immune system, and people like lupus and rheumatoid arthritis, colitis, Crohn's colitis, these kinds of disorders where they already have an immune system dysfunction and it's hyperactive. So in those cases, this may cause a lot more side effects, and they're not appropriate for every patient. Your healthcare team can help you determine whether this treatment, immunotherapy, is right for you. So what does it cost? Cost always is a big concern nowadays, as new treatments and each new treatment is more and more expensive. So many new treatments, including immunotherapy, are very expensive. Although patients who are being treated through a clinical trial may have those costs covered. Talk to your healthcare team upfront about the financial issues involved in your treatment. Talk to healthcare plan, your insurance plan, before beginning treatment to find out what the cost will be. And then many treatment centers have resources to help patients obtain insurance coverage or access to programs designed to help cover cost of treatment. So we do have the drug companies which have special programs to help patients get coverage. So is the clinical trial right for me? Be sure to ask your healthcare team about clinical trials. Clinical trials are research studies to test new treatments or learn how to use existing treatments better. A clinical trial may be the only way to get some of the newest and most promising treatments. Please be aware that clinical trials in cancer are different than clinical trials in other diseases. Usually patients with cancer do not get a sugar pill or treatment. They usually get the standard of care, which is the current norm of treatment, and plus or minus another additional drug. Participating in clinical trial means that you will receive the best available standard of care for your cancer or a new approach, which may offer improved outcomes. So what you should know about clinical trials: almost no one receives a placebo or sugar pill, like I said earlier, and you will be specifically told if this is a possibility. If you join a clinical trial, you can leave a trial at any time and can continue to get the standard treatment. So it's not a negative. You can always stop it. Every doctor does not offer the same trials. Even if another doctor is in charge of the trial, your doctor may still be able to help with your care. Most often, the trial pays the cost of the drug being studied, and your health insurance only has to pay for the standard treatment. However, your health insurance may not pay for everything, so be sure to ask. So what are different types of immunotherapy? So there are many different types of immunotherapy for cancer, including checkpoint inhibitors, other monoclonal antibodies, cell therapy, cytokines, cancer treatment vaccines, and oncolytic virus therapy. So I'll go briefly over each modality. So checkpoint inhibitors. So how do checkpoint inhibitors work? The immune system has safeguards in place to prevent it from attacking healthy cells. These safeguards are called checkpoints. They slow down or stop the immune system from attacking our healthy tissues. Some cancer cells have learned how to activate these checkpoints to avoid being found and killed by our own immune system. They trick the body into turning its own defenses off. Checkpoint inhibitors block these checkpoints, helping the body fight the cancer. So this is a nice cartoon of how the immune checkpoint inhibitors work. So as you can see, this is a normal T cell and a tumor cells. And this is, if you can consider this as a T cell receptor and tumor antigen, this is like an accelerator, and this is a checkpoint where this acts like a brake. So there's PD-L1 on the tumor side and PD-1 at the T cell type. Once the T cell gets activated, then either by giving a checkpoint inhibitor, so that means that this drug goes and blocks these two spots so that the braking is stopped and the accelerator is pressed. So these activated T cells help find the tumor cell and kill it. Most patients who receive immunotherapy today are on one of the two kinds of checkpoint inhibitors, which are called PD-1 or PD-L1 or CTLA-4 inhibitors. And not all cancers can be treated with these drugs. Currently, checkpoint inhibitors only work for up to about a third of the patients who are given them. But that number depends on the cancer type. So there are numerous checkpoint inhibitors which have been approved over the last several years. This is a relatively new area of drugs in development, and certainly this has revolutionized immunotherapy. So these are different names of drugs approved. Tecentriq, long names. I'm not going to list each one of them. The PD-1, PD-L1 inhibitors have been successfully used to treat specific kinds of advanced cancers, such as melanoma, lung cancer, Hodgkin lymphoma, Merkel cell, this is a kind of skin cancer, kidney cancer, liver, head and neck, colon, bladder, cervical cancer. One PD-1 inhibitor, Keytruda, has a new kind of very broad approval to treat any tumor which tests positive for this mutation on the tumor cells, called MSI or microsatellite instability, if they're high, or dMMR on the tumor cells. So this is just goes over different drugs approved for each of the drug has gotten approval for certain different indications or different cancer cells, but they all work in a similar fashion. I'm not going to list all of them. So combined therapy. So checkpoint inhibitors may be given in combination with other therapies, such as chemotherapy or other immunotherapy drugs. Researchers are also studying giving checkpoint inhibitors in combination with radiation therapy. So there is preliminary data that it may make the radiation work even better, or chemotherapy work even better. So other monoclonal antibodies, in part, is checkpoint inhibitors are one type of monoclonal antibody, but there are other types. Other types let the immune system find and destroy cancer cells using targets that aren't checkpoints. So still others take radiation or chemotherapy drugs directly to cancer cells. Each of the monoclonal antibody is made to find and attach to a specific protein that occurs in the cancer cells. And not all monoclonal antibody treatments are immunotherapy. Some are targeted therapies. Most monoclonal antibody treatments that aren't checkpoint inhibitors are used in blood cancer. So majority of them which are not immunotherapy, but they're used mostly in blood cancers. So here are different examples of monoclonal antibodies used for immunotherapy in blood cancers. So in ALL, they have CD19, CD22. So these are receptors on these leukemic cells. So essentially, we target a receptor on the cancer cell, which is widespread present on that cancer. So not every receptor is present on every cancer cell. So they pick a specific drug which works in that cancer. So like acute lymphoblastic leukemia, acute myeloid leukemia, chronic lymphocytic leukemia, they have specific drugs. And then Hodgkin lymphoma, non-Hodgkin lymphoma, multiple myeloma. So boosting the immune response. So next type of immune therapy is called cell therapy. In cell therapy, the body's own cells are removed from the person with cancer, taken to the lab and modified. And then it's returned back to the person, and these modified cells help find and destroy the cancer cells. The most common form of this treatment is called CAR T cell therapy. This is also a quite new therapy, which is in the last 3 or 4 years, which has come. It's a new form of treatment. CAR T cell therapy is approved to treat certain types of advanced leukemias or lymphomas, but it's primarily currently limited to blood cancers. But there are some studies going on in other solid tumors also. So there's a drug called Kimra and another called Yescarta, but there are several more which have come out. The researchers are also studying cell therapies called TIL or tumor infiltrating lymphocytes, TCR-T, CAR, NK cells. So these are other different kind of immune system cells which are being modified to improve response. And they are used in melanoma, cervical cancer, and blood cancers. So cytokine, that's another kind of treatment. So cytokine has been a kind of treatment which has been used for decades now. They do not target cancer cells in very specific manner, like some of the new checkpoint inhibitors do. They work by speeding up growth of our body's T cells by activating other immune cells, boosting the immune system generally. They do not provide a targeted response like some of the new treatment methods. The most common cytokines are interleukins and interferon. These are examples of cytokines that have been shown success in treating advanced. Usually they only have been used in melanomas and kidney cancers, where they have the most success. Cancer treatment vaccines. So unlike other vaccines we know of, which is given before the disease occurs, these cancer treatment vaccines are given once someone has been diagnosed. So this is not a vaccine in that sense that it prevents cancer. It actually a treatment for cancer. So these teach T cells to find and attack cancer cells that have specific proteins. Provenge or Sipuleucel T is the only cancer vaccine approved by FDA today. It treats advanced prostate cancer. There is actually another one approved for melanoma also, which is, I guess, newer than the slide deck. Vaccine to prevent infections that cause cancer due to HPV or hepatitis B virus exist, but they're not used as treatment. They're used mostly for prevention of cancer. But those are against the virus. Another form of immunotherapy currently used is BCG vaccine. So BCG vaccine, which was initially developed for TB prevention, is not used for that much here in the United States, but is still used in other countries. It's used primarily here to treat bladder cancer. So it's instilled, you go through a scope into the bladder and inject the bladder with this vaccine. It causes a general immune response in the bladder. It helps prevent cancer from returning at about 70% of the patients with early stage bladder cancer. It's primarily used in early stage of the bladder cancer. And then oncolytic virus therapy. So oncolytic virus, oncolytic basically means a virus which destroys cancer, uses virus to fight cancer cells. The one on oncolytic virus therapy currently approved in the US is used to treat a specific type of melanoma. Usually when melanoma is big enough that you cannot cut it out or is in a spot where you cannot remove it, but it's not stage 4 or advanced. So it's somewhere kind of in between. So you can inject this virus, this oncolytic virus into the melanoma, and it will go in and infect the cancer cells and kill it. So several other viruses are being tested in clinical trials for cancer, such as brain, breast, colon, and pancreas. I definitely know of in the glioblastoma of the brain, they've used poliovirus, attenuated poliovirus, and injected into the tumor cells, and it has helped a lot of patients. Now, what could be the possible side effects? Side effects from immunotherapy. We tend to think of immunotherapy as natural, as our own body's defense system. However, immunotherapy can still have side effects. These effects are generally different from those caused by chemotherapy or radiation treatment. In many cases, they are not severe and may be short-lived or easy to manage. However, less often, side effects can be very severe, persistent, or even life-threatening. The most common side effects can be flu-like symptoms like some fever, chills, headache, nausea, cough, loss of appetite. Usually they are mild, fatigue, rashes, redness, pain, soreness, muscle or joint pains, and rarely infection. Less common side effects can be colitis or other GI problems like stomach pains or diarrhea, problems in the thyroid gland, liver, kidney, heart, or other glands and organs, lung problems like coughing, shortness of breath, other serious autoimmune conditions as pituitary gland, which is our gland in the brain, secreting hormones, endocrine hormones, and diabetes. So actions you can take. Sometimes the side effects do not occur right after the treatment, and this may show up several months later, even after the treatment has been stopped. One study showed that the median onset of side effects is about 3 months. So it's not like chemotherapy where you get a treatment and immediately you'll have side effects. These can be slow to build up and can happen even after the treatment is finished. So little is known at this time about whether there are any long-term side effects. If you are on immunotherapy, it is important to let your healthcare team know immediately if you notice any change in side effect or symptoms. Most side effects can be managed if they are treated early. So sooner you recognize, the more effective the treatment is. That applies to even chemotherapy side effects. I'm going to create quite so distress. I'm going to skip in the interest of time. So definitely the cancer community support groups have different how to help with stress, and how to find support groups for your treatment. So future of immunotherapy. So definitely immunotherapy has a very exciting future. It is still a new field in cancer treatment, but new immunotherapy drugs are now available for use, while many more are being tested. Like I said, this is the new field, but it is rapidly expanding and has everyone very excited about it. Development of new immunotherapy is based on years of work by understanding how the immune system interacts with cancer cells. So research actually has been going on for at least 50 years on this thing. This is not new. Like I said, the cytokine therapy has been going on for 30-40 years. So tinkering with the immune system has been long being used to fight cancer and other diseases. As immunotherapy is further researched, new treatments will be developed that have the potential to change the ways in which we treat cancer, and may also lead to new approaches to prevent cancer, to preventing cancer. So this is all our cancer support community, all the resources. All right, Katie, do you want to take over? I think I went through this pretty quickly, so we have more time for questions and answers.
Yeah, that's great. We'll take some questions. If anybody has any questions, they want to enter them into the chat box.
And I think I can go over. Some people have already submitted the questions, so I can start with them. Please have a more general questions, because it's difficult to answer someone's specific question to a certain specific patient, because I don't have all the information on your specific treatment. So best person to answer that would be your own physician, but I can certainly answer general questions. So let me answer some of the questions which were submitted before. So one question was, is genomic testing used at all to determine who may be a good candidate for immunotherapy? So genomic testing is widely used nowadays because we have new drugs to treat specific genetic mutations. To check for immunotherapy, we have, it's not the genomic testing, it's actually like the PDL1 testing. So we have PDL1 testing, we have the MSI testing, DMMR, tumor mutational burden. So there are specific tests we do prior to immunotherapy, which tells us how good the response will be. So next question I had was, do cancer cells build resistance to targeted treatments like immunotherapy over time? If my cancer returns, is it likely immunotherapy would be repeated as a course of treatment? So yes, the cancers do develop resistance to immunotherapy. There's one thing is that some of the cancers in which we really, once they were stage 4, we never had a cure for them. But immunotherapy does have what we call a tail of in the treatment, meaning that a lot of patients, even stage 4 or advanced stage, do get cured. It's still small. It's about, in different cancers, it's different. But people do develop resistance to immunotherapy, and then you may have to go back to chemotherapy. Immunotherapy, once it's being used, currently it's not recommended that you go back after chemotherapy. But this is still a field which is researched, and but currently we do not use it again if you've had it before. The next question is, I have read antibiotics may reduce the success rate of immunotherapy. Is this true? And if so, should I be mindful to avoid antibiotics when seeking treatment for unrelated infections? This is a really good question. So there is truth to that there are some studies which show that certain antibiotics, especially Zithromax, in which it was studied, does reduce the response rate or effectiveness of immunotherapy. So So, but it is a balancing act. If you have a serious infection, you need to get that treated also. So I don't think it's a all yes or no answer. However, there is some interference of antibiotics with immunotherapy. So I do take that in. The answer, broadly speaking, is yes, but whether to avoid antibiotics completely, that I don't think I can recommend that. If somebody has serious infection, you can die from infection too, way before then. The immunotherapy has time to work. So I would certainly treat the infection if it's serious. If it's minor, if you can avoid it, then sure, you can avoid it. So next is, are there any recommendations of things I should do before beginning immunotherapy that could increase the likelihood of its success? So the main thing, I think it's more on our end, on physician's end, because we check all these receptor status and different various tests we do on our part to see whether how effective a therapy would be. From a patient's end, primarily, it would be to monitor the side effects and let us know as soon as possible, because the sooner we can treat them or address them, the more effective they are. Because like any treatment, this has also pros and cons, and the sooner we know, we can avoid harmful side effects. So next is, which cancers are most likely to require a combination of chemotherapy and immunotherapy? That's a very good question too. So essentially, it also boils down to our initial testing. So for different cancers, the criteria are different. In fact, even I keep a cheat sheet, because every cancer has a different cutoff for when to use immunotherapy alone and when to use a combination. So it is based on each cancer has a different, like PD-L1 receptors we check. The cutoff point on when to use immunotherapy alone or combination and all is different. So we do use frequently combining chemo and immunotherapy, but it's based on your specific tumor, and it's not by that it's lung cancer, it's one, and colon cancer is different. No, it's depending on that actually tumor cell, on what you have when we check your biopsy specimen. So other question is immunotherapy being used to treat other diseases outside of cancer? Of course, I mean, it can be used to treat infections, because that's another role of our immune system, and the main role is it help fight infections. So and also, like interferon and these drugs are used in many neurological illnesses, MS, hepatitis. It's used. So it's used in other blood conditions. So these treatments are used in wide variety of fields. It's not just cancer. So our immune system can modulate various other diseases too. So so it is used in many different conditions. All right, I think that's the list I have. So now we can open up to our forum there if people have questions.
Yeah, we got some great questions in the chat box. One kind of goes back to, I think, a question you had touched on earlier in regards to repeating immunotherapy. The question is, it seems there are many different immunotherapy drugs for the same cancer type. So if one immunotherapy drug doesn't work, could you use another immunotherapy drug?
No, because they all are working similarly. So essentially, when we look at how we target the cancer, cancer has different receptors on it. So we use combining, either chemo and immunotherapy. But if you've already used up immunotherapy, then they're all working through checkpoint. So all of those drugs are all working through checkpoint alone. So giving a different drug, but if it's working through the same mechanism, then it's not going to give us results. So at least of now, we are not repeating them.
Okay. And I think this one kind of asks about when deciding what kind of immunotherapy. The question is it the cancer type that primarily determines what type of immunotherapy someone would receive?
So like I said, the different drugs are approved for specific indications. So and specific stage. So So even like in lung cancer, for stage 3, there's a different one approved. For stage 4, there's a different one approved. Whether you got surgery first and then you get it, then there's a different drug approved. So each drug company has made a niche of which line or when to give it. So it's a standard FDA approval. So we look at the FDA approval, which drugs are approved in that setting. Whether if you've had first line chemotherapy, then second line it's approved, or third line. So we have a set recipe, I guess. The way the drugs was approved is the way we give it.
Okay. And this one, I think one of the slides talked about cell therapy specifically. In regards to cell therapy, can you talk about the process of removing your body's own cells? Is this something that generally happens in one visit, or is it a several visit long process?
So no, the removal. So basically, what they remove is they remove your T cells. So we have what we call pheresis center. So it's not done in our office, not done in a oncologist office. You go to, they have a pheresis center. They remove your blood, and they have a machine, like a dialysis like machine, where they tag and only remove the T cells. Then they take it to the lab, and then they process the T cells. They activate it. So they activated those T cells, and then you come back to your oncologist office, and we just infuse the activated. So it comes in a bag, and the activated cells we infuse back in. So it is a multi-step process, but you just one day of you giving away your blood, and then you receiving it back after the lab process after a few days, usually 3 or 4 days.
Okay. Another question we got, can you describe when you would use immunotherapy versus chemotherapy?
Right. So essentially, when we have an advanced cancer, we are checking them for the receptors for immunotherapy. So we are checking for the checkpoint, the PD-L1 receptors. So depending on the expression of the receptor is what we decide whether this will work or not. So if you have a high receptor count, then that means we have a good chance of immunotherapy working. So that's one way. The other is how sick the person is. Usually immunotherapy works fast, but combining it works even faster with chemotherapy. Or sometimes if the person is really, really sick, then we may just give initially chemotherapy and then transition them to immunotherapy. So it depends on patient factors, tumor factors, and what's going on. So it's a complicated decision. It's not as simple that every time we'll do this for this. So we have to look at a patient, we have to look at the tumor and the receptor status. So all of this thing combined, and then you decide.
This question is sort of along the same lines with chemotherapy. I know you had talked about the side effects. Can you I guess, remind everyone a little bit about the side effects of chemotherapy versus the side effects of immunotherapy, how they kind of differ?
Right. So chemotherapy, most of the time, the commonest side effect is low blood count. So, we have 3 main cells, usually white cells, red cells, and platelets. White cells help fight infections. Red cells carry your oxygen, and platelets help you clot. So usually chemotherapy suppresses so chemotherapy is more like a shotgun approach, that it will kill all cells, all fast dividing cells of the body, which includes the hair, which includes the nails, it includes the blood cells, which are the fastest growing, your GI tract. So if your white cell drops too low, that puts you at risk of infection. So usually a week after the chemotherapy, for most chemotherapy, different chemotherapy at different schedules, but your blood counts may drop, and you may have more extreme fatigue and tiredness, especially if your red cell count is low. And it's more immediate to the timing of the treatment. Whereas immunotherapy side effects is more, usually we see more gradual. So it's not a sudden that you get the treatment last week and this week you'll have these side effects. Usually, like I said, median could be even sometimes in months before you see the side effects. Side effects can be mostly fatigue, rashes, mild joint aches and pains. Those are common side effects, but they are usually very mild. and can be treated with Benadryl or Tylenol or things like that. It's rare to get serious side effects, but we do see them that because our immune cells are in every organ, they can affect the liver enzymes can get elevated, they can affect the lung, it can cause inflammation in the lung and pneumonia-like picture, even though it's not pneumonia, but not an infectious pneumonia, but inflammatory pneumonia, or sometimes even CNS side effects, memory or cognition issues. So can happen with chemotherapy, which we call long-term chemo brain and things like that. So they're a little bit different. The onset is different. The pace is a little bit different. So, and they're managed differently.
Okay. This one is specific to pancreatic cancer. Is there an immunotherapy treatment that's showing a good promise to treat pancreatic cancer?
So pancreatic cancer has so far been quite resistant, but there is still some research going on that. But so far, there's not an approved drug for pancreatic cancer in terms of immunotherapy. That is a very complex tumor, which has been difficult to break in. So there's some cancer, we thought lung cancer was difficult, but somehow we've been able to better define and find more targets. But so far, pancreatic cancer, like we said, we always are looking for targets on the cancer cells to attack. So if you have immune therapy targets, you go with immune therapy. If you have other monoclonal antibodies or other targets, you go for that. So far, there's not very good target identified in pancreatic cancer. So we are still using chemotherapy primarily.
Okay. This question goes back to one of the slides. It said there it was showing immunotherapy was showing some promise for some earlier stage cancers. Are there any specific cancers in the early stages that are using immunotherapy?
Yes. So breast cancer, in triple negative breast cancer, we are now even timing, we are using actually upfront, even before surgery, which has shown a lot of promise. Lung cancer, now it's actually approved for even stage 1 lung cancer. Before it started with stage 2. Usually in research in cancer, we start from the stage 3 or 4 cancer where there's not many options. And then once it works in that stage, then we move it up earlier and earlier in stages. So in most cancers, even bladder cancer, it's approved for very early stage bladder cancer. It's approved for early stage melanoma. It's approved for breast neoadjuvantly before surgery. Lung stage 1, it's been approved. So yes, there are several cancers, and there are new indications coming up all the time.
Okay, and I think one of the last questions we have is specific to prostate cancer. Do you know if there's a targeted therapy available for the AKT1 E17K mutation in prostate cancer?
So not immunotherapy, that's for sure. We have vaccine therapy for the Provenge I talked about. For that mutation, I don't believe I've read anything new come out. But these are all very new mutations which are being found, genetic mutations. I know for PAL-B, so there's a BRCA mutation which can cause prostate cancer, PAL-B2 mutation, which is genetic, hereditary. These are hereditary mutations in which we call PARP inhibitors, or they're specific to BRCA gene mutation drugs. They work. But the other mutations we have not so far that I'm aware of found a drug which works. So, but this is a new mutation. They're not very old, so we don't have a lot of history on them. But so that's why this is an active area of research.
Okay, and I think that's all the questions that we got in the chat box. I did put a survey link into the chat box. If everyone could please take that survey, that information that you provide us really helps us adjust and tailor the slides to best fit everyone's needs. So Dr. Singh, I want to thank you so much for being so generous with your time and expertise today. And as we wrap up, I want to invite you to share any kind of closing thoughts that you might have.
Yeah, I mean, immunotherapy is really, it's an exciting field. It's rapidly changing the field of oncology. It has, I mean, in the last, in just a couple of years, treatments for some of the diseases which were really difficult to treat have, we're finding so many people getting cured of diseases with immunotherapy. But however, I mean, I don't want to say it's cure for everyone. We still are tinkering with how to improve the chances of cure in each patient. So stay tuned and, always keep asking your physician if there's anything new, because I mean, every day I pull up my email and I have 3 new drugs approved. So it is a rapidly evolving and growing field. So I'm hopeful that, I mean, it clearly in many cancers it's replacing chemotherapy. So I think we'll see more and more of immunotherapy being used for more cancers and hopefully have less side effects. I mean, the cost is still an issue, and hopefully that will be addressed too. So thank you all for attending. It was my pleasure and honor to be here.
Yes, thank you again, Dr. Singh. If anybody would like more information on Dr. Singh, you can visit GwinnettCancerCare.com, and that's Suburban Hematology and Oncology's website. And again, I'll encourage everyone to please visit Cancer Support Community Atlanta's website, that's cscatlanta.org, where you can get more information on the virtual oncology programs offered. And again, if you know anybody that was unable to attend today's live event, you can encourage them to visit our website. We have a video tab where a recording of today's event will be posted. So thank you again, everyone, for joining us, and we hope to see everyone soon. Take care.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.